Thank you so much for the privilege of being with you today. My name is Jay Foster. I am celebrating 3 years with Indiana University Health. For 20 months of this time, we at IU Health, like you, have been working to address the ongoing pandemic. This is hard. However, I have to say what a wonderful community of providers, clergy, congregations, and nonprofits, all of whom are working together to address this. Let me also acknowledge this. We in healthcare have known for a long time how debilitating social isolation, loneliness can be. But with this latest surge, we are seeing it and living it with our patients, our families, ourselves. By way of introduction, let me say that I'm a healthcare chaplain and chaplain educator, and I was invited to IU Health 3 years ago to do a couple things. First, to promote the ministry of our inpatient chaplaincy team across the system, and second, to develop a pilot project working with congregations to address social impediments to health. So here are some of the things I'd like to talk about today, the objectives for this presentation. First, I want to describe the physical and emotional effects of loneliness. And then I want to pivot to a description of how healthcare systems across the country are addressing social determinants of health by partnering with faith communities. Then, third, I'd like to highlight our work addressing social isolation as a social determinant of health. And finally, I'll close with some critical questions we are considering at this point in our process. So first, some definitions. It is, of course, important to define what it is we mean by the broad term spirituality. This definition on the slide is taken from a group of accrediting and certifying bodies for healthcare chaplains. Here we're saying very simply that spirituality is the human need, the very powerful drive we all have to make sense of life, our purpose, our place, our connections with and for one another. And here's the thing, when you're ill and in hospital, or when your loved one is facing a grim prognosis, the chances are that your sense of meaning and purpose is compromised. This is where healthcare chaplains come in. This is where congregations can join in that work, we think. So in 2019, long before the pandemic, our spiritual care department made plans to come up with a program to partner with faith communities to address social isolation and loneliness. Of all the social determinants of health where we could focus our attention, transportation or food insecurity or housing, we chose loneliness as our focus for two reasons. First, we chaplains know something about walking with people at dark times of their life, in times of despair. Second, congregations know a lot about caring for the sick and the shut-in. On this slide, notice the distinction between loneliness and social isolation. You can be isolated from social relationships and activities, but not be lonely. Or you can experience a deep and pervading sense of loneliness in a whole crowd of people. Or, of course, you can be both isolated and lonely at the same time. We've all heard Dr. Vivek Murthy's name in the press recently. He is now having a second term as Surgeon General. In his first term, he wrote a book, Together, the Healing Power of Connection in a Sometimes Lonely World, and made loneliness the focus of his administration's work because he made the case, Dr. Murthy, that loneliness is itself a public health crisis. With COVID, we're getting a crash course in this lesson, and we're learning how interconnected these public health crises are. Social isolation complicates loneliness. Loneliness intersects with mental health crises or substance abuse disorder. All of these problems are interwoven with, complicated by economic and food insecurity, precarious housing. Pull at any thread of the spider web, it all shakes. Dr. Murthy's work picks up and amplifies earlier research. Some studies made clear that loneliness is like all emotional states. It's rooted in our biology. How so? Well, loneliness works as a trigger. hardwired into our nervous system to warn us when we are in danger of being isolated and alone. Why? Well, being cut off from relationships is like being cut off from food or water. Think about it. We as a species did not get where we are on our good looks or our physical prowess. We as a species have survived and thrived by our capacity to work together. When that capacity is threatened, we are threatened. So Dr. Murty points to the data. Now, this is a really busy slide, but let me highlight just a couple points. Prolonged isolation is like smoking almost a pack of cigarettes a day. For those in good health, and I think this is kind of an amazing data point, for those in good health, almost 1 out of 4 of us identify as lonely. But look what happens for those who are in poor health. 67% describe themselves as lonely. That's just a huge percentage of the folk who walk in one of the many doors of our health systems every day. That's just a lot of people who sit in the pews of our congregations. Not surprisingly, the data reveals the comorbid, that's a medical term obviously, but the comorbid relatedness of social isolation and loneliness with physical illness, emotional needs, or mental illness, as well as social and cultural factors. This is kind of apparent to us from our work in ministry, our work in the community. When there is a loss of mobility, a loss of hearing, a loss of sight, people may isolate emotionally and also experience pulling away from the more abled populations, or sort of double isolation. These factors have always existed. So what's going on now? Why an epidemic of loneliness when we are more connected, more informed, more resourced than at any time in our history? Well, there are a couple of factors, but let me mention 2 of the more obvious: our work culture and our social media. In the United States, we are driven to be available for work around the clock and driven to distraction by the myriad technologies, products, and entertainment that vie for our attention. This is all good, but overboard, not so much. In the Christian tradition, scholar Walter Brueggemann wrote a really fine little book recently called Sabbath as Resistance. In the book, he makes a simple point. Most of us think of the Sabbath as a matter of individual devotion, individual piety. Brueggemann says, no, it's more than that. It's really a civil policy. The landowner in ancient Israel responsible for everybody he was caring for, and he was required to place the rest and restoration of everyone working in that farm, actually even every animal working in that agrarian household, as sacred. No matter what the harvest was demanding, no matter what was needed in the fields, keep the Sabbath sacred. But these days, the tyranny of the bottom line threatens to undercut this idea of rest and restoration, leading to busyness over relationship, leading to getting ahead more than getting together. And the commodification of our personal likes and dislikes, this is changing our human connections in ways I don't think we fully understand. So, 2 data points here. Heavy users of social media are twice as likely to describe themselves as lonely as light users. Isn't that interesting? But here, another data point shows that moderation is the key. Adolescents who abstain altogether from social media are just as likely to describe themselves as lonely as heavy users. So some social media is really good, overuse, not so much. Here's the point. Many in our audience today are familiar with the idea of hypervigilance as related to trauma. Works like this. In the aftermath of physical or psychic trauma, we humans develop a hyperactive scanning of the environment. For example, the soldier on the battlefield quickly learns to scan for danger, to use every one of the senses, sound, smell, taste, to take evasive action. That same veteran back home hears a car backfire, drops to the ground for cover. Dr. Murty points out that a similar cycle happens here. Become lonely for whatever reason, the trigger is sounded. And guess what? Folk who are lonely tend to be embarrassed about their experience of loneliness, and so a shame response kicks in. This leads to an increased focus on the self. We worry, we fret, we second guess ourselves, which leads to isolating behaviors, and the cycle repeats. So that's a little bit about social isolation and loneliness. Now let me talk about the idea of hospitals and congregations working together to address social impediments of health. So, guess what? This idea is nothing new. My office is at Methodist Hospital, and when that hospital was founded in the mid-1860s, look up the original mission statement, and you'll see that it was to provide treatment for the sick, and in particular, to care for those who could not otherwise afford it. So the idea of hospitals and congregations working together to address health, nothing new, but it has enjoyed a revival in the last couple of decades. About 20 years ago, a Methodist pastor, public health scientist by the name of Gary Gunderson, came to work for the Methodist Laban Hur system in Memphis, Tennessee, led to the so-called Memphis model. Gary's idea was this: let's keep front and center that congregations themselves are the experts about barriers to health and the resources for health in their own backyards. The job of the medical system is to listen, to support, to partner, not to rush in like we know it all, but to meet the congregation and learn from them. So the Memphis model began with a chaplain by the name of Bobby Baker, who met with 12 pastors for over a year to engage the question, what would really help us meet the significant health disparities in our neighborhood? All this before they ever saw the first patient. They came up with what they call a patient navigator model, with the navigator employed by the hospital, but embedded with the congregation. Each navigator has 20 to 30 congregations in their care, and guess what? That network has grown from those 12 pastors to over 600 congregations, and from those few members to over 20,000 members. In this patient navigator novel, a patient comes into the medical center, meets with the navigator, and with that patient's permission, the congregation is involved in making plans to support that patient's specific needs when they're discharged and come back home. And what's really cool about this is that about 25% of the churches agree to see folk who are not their own congregants, but who live down the street and in their own neighborhood. Proactive mercy is smarter and cheaper than reactive charity. Dr. Gunderson can turn a phrase. In looking at the amount of money that is lost when patients get the wrong care at the wrong time, meaning when they get treatment at the emergency room for expensive care that comes too late in the illness, rather than the provision of good primary care over the course of a person's whole life, all of those expensive treatment dollars can be spent more wisely. Here is where my personal story intersects with the Memphis model. I was a chaplain with Wake Forest Baptist Health in Winston-Salem when hospitals do what hospitals do, and recruited Gary to come and build a faith health program in North Carolina. Gary said one simple thing that changed my vision on my day-to-day work as a chaplain. He said this: people don't come to the hospital to get well. They come to the hospital for treatment. They go home to get well. And if they don't have what they need at home, not food to eat or safe environment to recuperate or loved ones to care for them, chances are they will not do well, come back to the hospital. There are lots of efforts, both large and small, to work with congregations, community agencies to meet those needs, to address those health disparities. One of the larger efforts is called Stakeholder Health. It's a consortium of more than 40 large medical systems across the country, most of them with ties to a religious tradition that form, and the Stakeholder Health forms a learning community. Each one of those 40 health systems has developed a model for partnering with congregations, including the patient navigator model with Memphis. Several hospitals use a care team model. Faith Health of Wake Forest in North Carolina employs community health workers and uses what I call a connector model to amplify the work of congregations. I'll say more about this model in a bit. But maybe more inspiring than the big systems are the thousands and thousands of small community efforts across the country where folk are working on this. Here's the good news. All across the country, just like in this conference, clergy in the community and the health system are working hard to connect these resources more efficiently. So there's a power in these community efforts that I think we in the medical system would do well to appreciate. For instance, the social determinants of health is a powerful concept in the field of public health, but is not very good theology. The idea that your zip code determines your outcome as a human, this is to miss the power and the spirit of our human being. My friend Dr. Gunderson grew weary of going to public health seminars on the leading causes of death and pointed out that churches and communities in areas that are hard-pressed by economic reality, these communities have wisdom and strength. He wrote a book, Religion in the Public Health, in which he outlined the leading causes of life, where there's connection with one another, where there's coherence, a sense of purpose and mission, where we have agency over ourselves, where we're generative and can create and give back to our community, and where there is hope. Where there are these 5 leading causes of life, there is a force that leads us to more life and more health. So one of the more important goals of our effort at IU Health is to listen to congregations where we can come along and learn with them to address the leading causes of life. So this is background about faith and health generally. Let me turn to our pilot project. In introducing this work to potential congregations, I begin with this slide, explaining that the social impediments to health have greater impact on outcomes than do access to great medical treatment alone. I then quote Frederick Buechner, a Presbyterian pastor, on the idea of calling. Buechner says this, that we have found our true vocation when our particular gifts meets the world's particular needs. In addressing social isolation, this all matches up. Our gifts as chaplain and their gifts as congregation match up to meet the very human epidemic of loneliness. Here's how the program works. It's really pretty simple. We form partnerships with 8 congregations in Marion County and 2 in Monroe County. Each congregation recruits a small team of 6 volunteers. We call them connectors. The idea is to help persons reconnect with their own spirituality, their own coping skills, and then to help them connect with social networks and community resources. We provide a small grant to the congregation of $1,000 a month. This can go to any program they want, but we suggest that it go to support a lead volunteer or to organize the work. That takes the lead connector, lead volunteer, about 8 hours a week. Either way, the grant supports the congregation to extend their ministry beyond their doors and to their neighbors. Our target population are patients 50 and older with who have a chronic illness, who live in neighborhoods that our hospital has identified as under-resourced. Our chaplain meets with the patient prior to discharge, explains the program, namely that they can meet with a volunteer trained by our hospital staff, and that volunteer will spend an hour with them a week for 6 to 12 weeks and be their companion as they adjust to getting back home. This is the intervention. We believe that the power of human connection in and of itself, the power of mutuality, of care, of love really, that this will make a real difference in the life of the patient. And we know this to be true. If I spend an hour really listening to you and we really and truly connect, I'm going to learn all kinds of things. Maybe there's food insecurity in the house, maybe there's substance use disorder or domestic violence. And the connector knows how to then connect that individual with a community resource or the mental health provider or the recovery program that patient needs. And this, I think, is our secret sauce because we value the relationship more than anything else. We will continue to provide care whether or not that referral takes place. Often enough, it takes any one of us to be ready to raise our hand and say, yes, I want the help that's being offered. And so that connector stays with the person and sustains them while they get across the door to get the help they need. By the way, we have a terrific licensed clinical social worker on our team, Tricia Beringer, who helps to educate connectors about those resources. In fact, can take over if they are presented with a problem that's beyond their scope. She's supported by our program manager, Shadrach Kamwindo, and our administrative coordinator, Sherry Session, and several of our chaplains, Tasha Howard and Rob Brown, round out our team. So, here's the deal. We were all set up to send out our connectors 2 by 2 into the homes of these patients when the pandemic hit. Older volunteers going into the homes of older patients with a chronic illness, not so much. So we changed to telephone and video platforms. And the good news is this. With the pandemic, everyone now really gets it. Social isolation, loneliness, these are real. And congregations get it. They want to reach out to their own parishioners, and they're also a lot more comfortable with this technology and motivated to help their neighbors. So it's working really well. The key to what we offer is training and support. We use a very well-established curriculum called the companionship model out of Seattle, developed by their mental health chaplaincy. It was originally designed to companion those living with homelessness and is well suited to this purpose. The goal of this training is to build a relationship with the individual, to support her or him as they rekindle, rediscover their spirituality, their internal coping skills, and then to encourage them to develop real, deep connections with other networks of care. Now, that might well be the congregation the connector is part of, but it also could be a social club or family connection or another congregation in the area. The training stresses trust, boundaries, listening skills, empathy. Let me emphasize this. These skills are not rocket science. These are not hard theories or skills to understand. It's kind of like playing the piano. It's hard to do. It takes practice, and it takes support. So each group of 6 connectors in the church commits to meet with 1 patient a week, maybe 2 patients a week at most, but then they commit to spend a whole hour a week with one another to have the support, encouragement, and guidance of their team so that together they can learn to care for their neighbors. One of our staff chaplains serves as a content expert for that group, so they can always call on the chaplain for some guidance about how to do that. Let me tell you a couple of brief stories to highlight this. I'll call the first person Rebecca. So our chaplain went to visit Rebecca, and she said, I'd love to be a part of this program. I'm older, and I moved from my home in St. Louis to Indy a couple of years ago to be with my daughter, and my daughter's wonderful, but I have no friends my own age. And one of the connectors from Light of the World congregation here in town developed a great relationship with Rebecca. In fact, I think, truth be told, they're still in touch with each other. And Rebecca became connected with a group of friends her own age. Another story, let me call her Donna. She's a member of one of our family practice clinics. Very well connected with her provider, very well connected with her social worker. But it was her volunteer connector that she built enough trust with to say, you know what, I've run out of money and I've started rationing my own medications. The connector encouraged Donna to call her healthcare provider back. The provider connected her with their clinic's social worker. They figured out how to get her the medication she needed so she didn't need to ration her medications while meeting her monthly budget. Our goal is to support a spiritual journey, a journey built in an ideal that is fundamental to all traditions, all faith groups. Namely, we humans are most healthy when we love our neighbor as we love ourselves. This is an idea that makes no sense whatsoever if we don't first love ourselves, befriend ourselves. Learning to be alone, actually, learning to be comfortable in our own skins is part of the secret to that, to pay attention to our own heart and mind and spirit. This spiritual journey is the antidote to loneliness. And here's the irony. This learning to be by ourselves happens best within the context of healthy, supportive community, healthy, supportive relationships. So our program has grown, in fact. We started with 10 congregations, and now we have 15 that are involved in the program. Each congregation, as I said, has 6 connectors, and each connectors meets as a team 1 hour a week to discuss their needs and opportunities for the companions. This is really the centerpiece of the program, is that the group loves each other, and from that loving relationship, they can better love the companions they're caring for. Mother Teresa said that for every hour that you spend in the clinic caring for someone else, you need to spend an hour in the garden. That small group is their garden. Guess what? All the lead connectors from those 15 congregations then agree to spend a separate hour once a month with each other to share the best practices and unique resources from their congregations. This is really a wonderful secondary benefit of the program, that congregations that have been right down the street from each other are now working together on this program. To determine the effects of our program on social isolation, we give a brief survey at the time the person was enrolled in the program and repeated the survey 12 weeks later. The survey is a validated instrument called the De Jong Loneliness Scale, has 6 items. 3 are about emotional loneliness and have items such as, I miss having people around me. 3 address the issue of social isolation. An example of one of those questions is, there are plenty of people I can rely on when I have problems. We compared the pre and post De Jong scores to see if our scores made an impact, and we found, as you can see in this slide, that the total score went down, meaning that patients reported less loneliness at the end of the program. We had a major effect on emotional loneliness with a statistically significant decrease. We were not able to have as much of an effect on social isolation. Some possible reason for that is that COVID continues to hinder social gatherings, and frankly, it's very hard to move persons out of their own isolations to fully connect with other networks. One final note is that these results are adjusted for age, race, and gender, and even after accounting for those factors, we made an important difference. So in summary, the early results show that congregational care network have a significant impact on the loneliness that our patients have been facing, and this impact on their loneliness has a direct impact on their physical and mental health. So here's the news that everybody at this conference knows. There is a great opportunity of health systems to partner with congregations. Data, in fact, shows that when a person who reports a spiritual connection with a religious tradition or congregation, these patients have significantly better health outcomes. Similar research shows that our patients who are connected with congregations have a much deeper trust in their houses of worship even than they do with hospital systems. So there's great opportunity to connect with a patient who's lonely and provide them with a companion. But I think it's also important to note that there are dangers of which we need to be aware. So here's what I think we all know at this conference. There's a great opportunity to connect a patient who's lonely with their companion. But there are also dangers of which we should be aware so we can take heed. In my part of the country, I've heard it said, there is no hurt like church hurt, meaning when the church itself abandons or neglects someone, how painful that is. So the danger is this: what if a patient experienced a companion as betraying their trust? What happens if an old church hurt wound is triggered, and maybe the connector doesn't even know about it, but we learned that in fact we've done more harm than good. There's interesting research also that calls for a better, more refined methodology to look critically at all kinds of spiritual practices and religious traditions to make sure that those do in fact support good health comes and to pay attention to those not so much. So clearly I believe that the wise thing to do is to pursue these opportunities, and I'm also clear that we need to be smart and humble about the potential harms. Many of us, religious or not, many of us are fearful that our particular way of doing things, our worldview, may lead us to privilege one point of view and diminish another. So a really good friend of mine, Dr. Russell Jones, has written a really helpful book. He's a psychotherapist, and he wrote this for other psychotherapists who were not themselves spiritual religious about how do we thoughtfully engage this very important part of a client's life and recovery. Russell offers this simple way to discern what's a healthy spirituality and what's not. He puts it like this: does a person's spirituality help her or him make sense of a complicated world? Does it increase her sense of agency? Does it help her treat herself and other people more fairly? Does it give her life a sense of purpose and meaning? If so, then let's call that tradition healthy. Or does it make her or him more fearful, more agitated, more hostile? Does it isolate him from others or from parts of himself? Does it confuse or weaken him or his experience of agency? If so, let's call that harmful. So yes, there are dangers in working in the field of spiritual care, dangers of oversimplifying the real differences between people or of imposing one worldview on another. Awarenesses of such dangers, that's the first step to addressing them. Good and robust communication, that's the next step. We think the opportunities are great, and here's what we're learning so far. Congregations have many, many resources. They don't always necessarily have a good way to introduce those resources to their neighbors. When those neighbors are our patients in the health system and become known to us in our clinics, say by using a validated loneliness scale like the Dijon scale, those patients can be offered a referral to our program or one like it, and that could lead to meeting any number of related public health concerns. So in other words, the trust that's put into one of our healthcare providers can be shared with your faith community, and the trust of your faith community can be shared with our health provider when there is a true and real partnership between us. So, thanks so much for your time, and I really appreciate the ministry that each of you is engaged with to make our community a healthier place.